Hi, I'm Bridget Milden from FND Hope, and we're here today with Professor Mark Edwards, a neurologist at St. George's. And thank you for being here with us today. How are you?
I'm very well, thanks, Bridget. It's a pleasure to be here, as always.
Thank you. We wanted to just start a little bit, find out what you have been up to. I know you do a lot of webinars for us, but if you could kind of just give us a brief overview of where you're at and how things are going.
Sure. I suppose every year things, to me, from my side, look more and more promising about FND. I know that it may not seem like that for people who are waiting an enormous long time to get help or get treatment and so on, but there is so much more happening than there used to be, and particularly thanks to organisations like FND Hope. From my point of view, about 3 years ago, I moved to St. George's Hospital in London from the National Hospital for Neurology. And one of the reasons for doing that was to try and establish a more, if you like, real-life, fully functioning service for functional neurological disorder. And with a number of colleagues, we're getting there to do that. And what we're trying to establish is a kind of full pathway or ideal pathway for people with functional neurological disorder. So that needs to go right from the acute services like A&E and the hyperacute stroke unit to neurology outpatient clinics. And then with specialist neurology-led clinics, we try and then help reach a diagnosis, explain the diagnosis, and then most importantly, try and find a way to triage people into effective treatment. And we know that, as you all know, that FND is a very, very variable condition. People have lots of different symptoms, different severities of symptoms, different other problems. And so what we try and do is work out what the best treatment might be and push people in towards that sort of treatment. And then to try and follow people up and give people some long-term care. And the idea is if we can set up that whole pathway, which is a tricky thing to do, then we can get money to evaluate that and really try and prove to the world, particularly the world of healthcare and government, that having a proper service that looks after people with FND with specific and specialist care helps people improve and also probably saves a lot of money as well. That last part is not necessarily the reason why we're doing it, but obviously it is important to try and convince people that have the money for healthcare that this is the right thing to do. So that's one big project which is ongoing. And at the same time, with Glenn Nielsen and a number of other people in the UK, for example, John Stone, we've got research funding from the government to do a specific trial of physiotherapy for functional motor symptoms, building on work that in particular Glenn has been doing for a long time. And that trial is now recruiting. We've recruited nearly 50 patients now, and we're trying to get to around 300 patients. And we're going to look at whether physiotherapy for functional motor symptoms, does it work? How well does it work? Again, is trying to get proper evidence to show that hopefully this is the thing which helps a proportion of people, and therefore it needs to be funded. So that's the main. Thank you.
Yeah, that's fabulous. You've definitely been busy. Next week we'll actually have Glenn on, and he's going to talk about the program. So anyone that is interested in learning more about that, he's going to go kind of in depth a little bit on what you're doing, why you're doing it, things like that. But I want to kind of go back a little bit to what you talked about, the care pathways and how important that is. I think so many patients find themselves getting in an ER or in other areas, and it stops there. And I think a lot of times medical professionals want to help, but they don't know what to do next and how to move forward. Do you find that a lot as you're?
Absolutely, and I hear it from doctors all the time. I think, generally speaking, I know a number of people with FND might have had some negative interactions with doctors, and I know there's some sort of like bad apples out there, but I think most doctors and nurses and therapists do want to help. I think often the problem is that they don't really know what to do, and they haven't got a service to refer to. They don't really know how to help, so it ends up in a really difficult situation. But if we can provide doctors and therapists with options, so first of all, skills about how to help people with FND that they're seeing, but also ways to refer people on and where to do it, then I think everything would work a lot better. I was sitting with a doctor in clinic the other day who's a trainee where I work, and she was saying that recently she'd seen a person with FND in her clinic, and knowing that she had a clinic to refer that person to made the whole thing so much easier. And previously it would have been a bit of a nightmare and probably wouldn't have gone very well. The whole thing went really well, and the person seemed to be satisfied. They got a referral to a treatment service. So, we just need to start treating FND just like we treat everything else. We have MS services, headache services, neuropathy services for a reason, which is that when you have a group of people with a significant medical problem, they often need a specialist service and different types of treatment. And there isn't one type of treatment for MS. There's lots and lots of treatments for MS, just like there should be for functional neurological disorder. So what we're trying to do is do something really quite normal. So it's not reinventing, inventing something completely strange, but it's just for some reason, people with FND have never been able to have that sort of service, and they should do. I think it would work.
That's fabulous. I think you're right. It's ironic that you're just trying to create a normal pathway to healthcare that all patients should be able to access anyway, but there's so many obstacles in knowledge and education that needs to take place, I think, on the medical side and patients. I'm sure it's very helpful if a patient also knows, what are those pathways, so when they aren't happening, they know how to pursue it. We have a question, and just for those that are participating with us, if you have a question for us, feel free to put it in the Q&A chat that should be available to you. Depending on what kind of computer you have, it will be in different places. But feel free to send your questions to us, and we'll try to answer them all. We have one question. She's asking if there is a new inpatient program. I'm assuming maybe that's in the London area or in your program.
Yeah, I think so. So in the UK, I know many of you may be from outside the UK, but in the UK, there have been two very long-established programs, both of them in London, unfortunately for people who live outside London, but one of them at the National Hospital for Neurology, one at the Lishman unit at the Northey Hospital. And there have been others as well around the UK. But we've opened recently some beds at the Wolfson Centre for Neurorehabilitation, which is the rehabilitation unit that's attached to St George's Hospital, which is it's a neurorehabilitation unit that's been going for a long time, but up until very recently would not take people with functional neurological disorder, in common with many, many other neurorehab units. So with neuropsychiatrist Mike Dilly and now Chris Simeon, along with a therapy team and so on, that's now open. Unfortunately, as is the case with all services for FND that open, as soon as you open something, it's immediately full and full to bursting. So immediately develops a long waiting list. And this is part of the whole, coming back to the pathway thing, is part of the point of trying to do that. Because until you have services in lots and lots of places, it's never going to work, because there's always going to be too many people for the services that exist. So we have to prove within a region, I think, that having a pathway works, and then we can use that to say, well, every region should have this, every region should have an FND clinic, every region should have an inpatient program, because that's the only way you're going to be able to help all of the people that are out there with FND. But yeah.
Well, and one of the things you'd mentioned with your pathway is having also some follow-up type care, and that brings us to one of the questions that someone has asked. They've tried physio and speech therapy, and they've had treatment, and obviously they're still having symptoms because they're still feeling at a loss of what they could do. Is there other things available? I know OT is getting more involved in.
So I think that functional neurological disorder, like any other neurological disorder I can think of, it's very different between different people. The different severities of symptoms, different types of symptoms. The people themselves are different, so they have their own background, medical or mental health problems, maybe. So there's a whole, they're in their own particular social setup. So everybody is different. So the ideal situation would be that somebody with FND can come to a clinic where they can be listened to, and to talk about all of the different things that are going on, and you take a holistic view of everything that's happening and trying to think about what the most appropriate treatment is for a particular person. And for example, it may be that pain is the sort of dominant problem. And if pain is a dominant problem, then it may be that a pain-specific treatment might be most useful, first of all. If it's movement problems, then it may be that physiotherapy would be a most useful option. If there's a lot of stuff going on, then it may be that multidisciplinary rehabilitation would be most helpful. So I think that generally speaking, if people have severe ongoing symptoms which are multiple, then it's usually the case that multidisciplinary rehabilitation is the best kind of treatment. However, there are people where that is also not that effective. So people who have very, very significant fatigue and pain, so that it's very difficult for them to do anything in terms of active rehabilitation. The kind of intensive treatment you have in an inpatient program may make symptoms sometimes worse. You can see that there's a lot of skill needed, and we still don't have all the answers into how you choose the right treatment for the right person. I think there's another side to this, which is that like any condition that's real, it's not always the case that treatment works, and that's a reality, unfortunately. I hope it's going to be less and less of a reality as we get better and better at helping people, we have better understanding of the condition. But it is just a fact that whatever treatment, however good the treatment is, sometimes people don't improve. And that's an extremely hard situation. But it's even in that situation, it's not the same as saying, well, there's nothing we can do, because supporting people in the right way, trying to help them get the most out of life, even though lots of symptoms are going on, is part of healthcare too. It might be a bit different. It might be happening more within people's homes. It might be more therapies based or more general support. But that's kind of a job of a health service as well.
Well, I think it's important too to remember it's not the patient's fault because they're not getting better. You know, we are always trying to promote, you know, hope, and it's a possibility. And sometimes that is misconstrued from with patients and their families that oh, well, they say you should get better, so you should get better. And when it doesn't happen, they start to blame their family member or themselves, you know, however that works. And so I think it's important that you mentioned that.
So FND is not, it's not somebody's fault that they have FND to start with, and it's not their fault that things sometimes don't improve. And I know that the way that often the diagnosis is communicated as, you know, there's nothing seriously wrong, or your scan is normal, that's great. Well, obviously it is normal that the scan is great, but it doesn't mean that there's nothing wrong. And in fact, FND is a very serious condition. We know that from the way that the disability that people experience, even in the long term. So we need to recognize that it is, you know, being a real condition, it is going to be the situation that for some people it's not going to improve. And we need to have a way of trying to help and support people in that, and recognize that it's not people's fault. I recognize that sometimes there's things written in the medical literature about the importance of acceptance of the diagnosis, and somehow the acceptance of the diagnosis is sort of a magic pill that kind of, and then it's all gone just by accepting it. That's not true. And that's, I mean, I know people, sometimes doctors go on about that, but that's not really what that's trying to say. I suppose it's trying to say that by understanding what it is that's wrong, that can be helpful in its own right. Not by magically getting rid of symptoms, but it does help. Just like when I see people with, you know, symptoms which I think are due to Parkinson's disease, and when I tell them, oh, this is Parkinson's disease, although it's not very nice news, often they say that they're relieved that they finally know what it is. And actually that does help generally in managing the situation. So I think that's the case for FND as well, that understanding what it is that's wrong and getting some knowledge about that and feeling that makes sense as a diagnosis, that's helpful. But it's not a magic trick that somehow makes the whole thing disappear. And I know that's somehow how it's presented a bit in the medical literature.
Absolutely. And I think trying to find the right words to communicate what each side is trying to say and get across, because I often see that misunderstood between patients and the medical community. And I think that you just put it very eloquently, you know, how they do go together. One of the questions, you know, too, we mentioned about sometimes it does just go away. And we have a question about those that maybe do have their symptoms go into remission. And when that does happen, is that usually permanent? Or do we know?
Yeah, so I think it can be. So in in the big study that John Stone and Alan Carson did in Scotland, finding people with functional neurological disorder presenting for the first time to neurology clinics and then following them up. At 1 year, about 25% of people would just said they were better. So those people have generally not had much or anything in the way of treatment, but it just improved. Now, I think that for a proportion of those people, it probably does stay better. And for a proportion of people who maybe have longer term symptoms but then go into remission, I think it can stay better. I think that it's often more likely to stay better if people have a good understanding of the diagnosis and maybe have an understanding of whether there were factors that did make it better. So did they have a treatment, or were they doing something themselves that seemed to help the problem? Or maybe I see many people where they have functional neurological disorder, but there is another condition which is driving the problem underneath. So that could be that they have chronic migraine, or I've seen somebody who has sleep apnea, or they have a mental health problem like anxiety, or they have significant stressor in their life. So these are not the same as FND, but they're driving it. And sometimes with resolution of that, the FND symptoms reduce, might even go away. So I think it's often important to look around. You have the FND itself, but you look around that as well from a medical, social, mental health point of view, and look at whether there are driving factors which are making the situation worse, which could be treated in their own right. Because if they are, then sometimes the problem improves.
Most definitely. Another question that let's see, we've got a lot of questions coming in. It's hard to kind of see which ones flow from where, but someone had asked about nutrition, and this does come up on our pages every once in a while. Has anyone looked into nutrition on any studies or anything that you're aware of, or have you found that to be beneficial?
So I think it depends what you mean by nutrition. I think that at a very basic general level, good general health, I think, is likely to make the problem somewhat better, you know, and so that includes having a good diet. I think that there are some people who have, and this is an example of a driving factor, some people have, you know, allergies, intolerances, things like that to food, which are giving them symptoms in their own right and are making the FND worse, in which case dealing with those through diet can be helpful for some people. I don't think that there's any evidence that there is a specific food stuff or, you know, dietary supplement that is a magic bullet for people with FND. A lot of people with FND who have had the problems for a long time, because of relative immobility often, and just the general effects of having a chronic disabling problem on the body, I think there are quite a lot of people who are deficient in, so I see a lot of people with vitamin D deficiency, vitamin B12 deficiency, vitamin C, you know, there are, and obviously those things can have broad effects on the nervous system and on well-being. So having a general MOT, general checkup in terms of, you know, your general health, including those sorts of things, is a reasonable thing to do. And if those things are low, then they should be replaced.
Can you give any advice maybe to a patient that feels like that they're going maybe to their GP and everything is being dismissed as FND? You know, sometimes we'll see a lot of like symptoms and things, and I'm thinking, you know, they possibly could be FND, but they can be something else. And, you know, how do patients navigate that on maybe when to go to the doctor, or then how to approach their doctor about that? Do you have?
This is a really, really good point, and it's something which I talk a lot to doctors about, because part of it is their issue, really. So I think there's a fear within doctors that by reopening investigations, so say somebody with FND comes with a new symptom, by reopening investigations, they're somehow opening Pandora's box, they're somehow going to make the whole thing a lot worse. So I think that's generally not the case, but there is that fear there. And so often that's one reason for the sort of resistance to investigating things. What I say to doctors is that if a person with FND comes with a new persistent symptom, then that needs to be looked at in a reasonable clinical way, just like you would anybody else. Of course, it may be related to the FND, that's true, but it may not be, because people with FND can perfectly well get other medical problems. People with FND, we know already, often do have other medical problems anyway, which have acted as triggering events and so on. So, you need to take those new symptoms seriously. That doesn't always mean investigations, but at least it means listening to them and potentially organising investigations and so on. So I think if a person is struggling with getting that through, it's difficult when but you need to, I think, approach maybe by understanding what might be going through the doctor's mind, which is that, oh no, I'm gonna spark off all of this, everything again. But you could say, well, look, I know I have FND, and I appreciate that can cause lots of symptoms, but this is a new thing for me, and it's not just been for 5 minutes; it's been there for days or weeks. I'm worried about it. What could we do to look at that in a bit more detail? So just sort of that might be one way to get through if you're having trouble. But I mean, personally, in the clinic letters from our clinic, we always put at the bottom, the doctors that work on the clinic, at the bottom, if a new symptom emerges, this needs to be looked at in a reasonable clinical way. And I've certainly seen a number of people who've got very obvious other problems, like chronic migraine or things like that, which are not being treated because people are just bundling everything up into the FND diagnosis, which is not the way it should be.
That's really helpful, because I think that is always an issue for patients trying to decide, when and how. And that some of the questions, we're getting a lot of questions in, some of them kind of go together and correlate. And so we really touched on a couple of them. We've had a couple questions come in also regarding the difference between FND and fibromyalgia. Also some question regards to like chronic fatigue syndrome. Can you kind of touch a little bit, like, are the commonalities, maybe how?
So this is a complicated issue, and I think it's a complicated political issue as well as a complicated clinical issue, particularly around the diagnosis of any chronic fatigue syndrome. What my feeling about this is that symptoms from the body, like pain and fatigue, can be part of the brain dysfunction or brain problem that underlies functional neurological disorder. So to me, functional neurological disorder is a problem in this interface between your personal experience or conscious experience of what's going on inside your body and your body itself. So that when you try and access your body in terms of movement, that often doesn't happen in the way that you want to do, and often the body's doing things you don't want it to. But it works the other way as well, so that signals coming from the body, which may be signaling that everything is okay, are distorted and changed by the way the brain's processing them, so that people experience real and disabling symptoms, which can include pain and fatigue just as much as they can include sensory loss and so on. So that is what FND is to me. So it stands to reason that people with FND may experience chronic pain and chronic fatigue. Chronic meaning it's lasting a long time. And that is what you see in all published studies. Say if you take a group of people who present with a functional movement problem and you ask them about pain and fatigue, upwards of 80% of people also have pain and fatigue. So that's just a fact. There's a different question, which is whether any chronic fatigue syndrome is the same thing as functional neurological disorder. Personally, I don't think it is, because I think that I don't think anybody knows exactly what ME chronic fatigue syndrome is. And people who are expert in that area, including patient experts, would all accept the fact that it's likely in that diagnosis, likely to be probably lots and lots of different causes for that. And I think that this diagnosis of fibromyalgia is the same sort of situation. So where does that leave us? I suppose it leaves us in a bit of a complicated situation. So I would never say that I could explain any CFS in the same way that I was explaining functional neurological disorder. But I think that fatigue and pain are a key part for many, many people of functional neurological disorder and the specific way in which the brain is going wrong. And because of that, treatments which may be useful for chronic pain and chronic fatigue, particularly from a rehabilitative point of view, are likely to be helpful. So we can gain knowledge from treatments that have been used for chronic pain and fatigue for a long time and probably apply them to people with functional neurological disorder. And that's what we're trying to do in my own service, which is to draw in the chronic pain management program or aspects of that into the service for functional neurological disorder, so we can help us, help gain from their knowledge and experience.
Well, I think a really good point, though, that you try to make, in all that is that we're all trying to make sense of it, and that people are looking into it, and where it has gone for many years in the past, the research maybe hasn't explored other areas or other causes possibly, that doctors are more open to that and researchers are more open and acknowledging that, sometimes we just don't have all the answers and we can only work with what we have.
I think that's been part of the problem with FND for a long time, which is that from the doctor side of things, there was a very, very strong sort of almost dogma that the reason why people develop FND is related to is caused by past trauma. And that is just not sensible. It doesn't make sense. And it doesn't make sense because we know that there's many, many roots in terms of risk factors that seem to make people more vulnerable to developing functional neurological disorder. And short traumatic experiences is one of those risk factors. That doesn't explain function. That isn't functional neurological disorder. That's a risk factor that makes people more vulnerable to developing the problem. Just like having high blood pressure is a risk factor for having a stroke. That doesn't mean that everyone has high blood pressure has a stroke, or everyone has a stroke has high blood pressure. So the medical profession has been at fault, I think, for having this very sort of dogmatic view and sort of somehow pretending that we know all the answers already. This is not true. FND is the same as many, many other conditions. We know some of what is going on. I think we have some growing knowledge about what's going on in the brain, some knowledge about risk factors, but we definitely don't know everything. But that's okay. That's why we need to approach it in a normal scientific way and study the problem. And we'll end up with lots and lots of answers by doing that. But if we just stick on one sort of narrow path, then we're never going to find the answers.
Absolutely. And, someone was asking about autoimmune disorder, can that also cause some fatigue and can it trigger some FND? And even if you're accepting the diagnosis, and absolutely, from what you've talked about, I think that would definitely fit along with all of the other illnesses that we've mentioned. Another, as we're all trying to kind of explore this, we've had a couple questions from some different, someone wondering if you would work with PhD students who are looking to do research, and also some other questions regarding treatment, teaching GPs and some of that. What type of engagement do you have? Do you have PhD students working with you?
I do. I have done. Glenn was my PhD student a little while back, and so yes, I do, and I have done in the past, and others do as well. And I'm really it's actually in some ways quite an emotional thing when I get people coming to me sometimes and saying, "Oh, I'm really interested in doing FND as a career," and that's something that I don't think would ever have happened, 5 years ago, 10 years ago. So get neurology trainees coming to me and saying, "I'd like to subspecialize in FND," and the thing that's most interesting about that is that younger people coming through who've had this experience of FND being a kind of more normal thing, it doesn't seem that odd to them to think, well, actually, there's some people who like to do MS, some people like to do Parkinson's disease, I'd like to do FND. It's kind of a natural choice rather than being this sort of weird way out thing to do. So that is happening, and you can also see it from a research point of view. And interestingly, when you go to pure sort of basic scientists and talk to them about FND, they're really fascinated by it, because again, they haven't got any of this baggage necessarily about, what it might be. They view it as a scientific problem to be solved. So a lot of us do sort of training and engagement work with all kinds of different people, GPs, psychiatrists, neurologists, doctors, A&E people, etc. But it's starting from a very, very low base of knowledge. Particularly, I think within neurology, it's much better than it was. I think within general medicine, particularly in acute medicine, it's still not that great. So there's a lot more to do, but we're trying to do that through. There's now an international society of functional neurological disorder. So that's a big step forward. There's going to be an international conference next year in the US, but with people from sort of internationally. So there is a real buzz about the subspecialty, and it's again starting from quite a low baseline.
Yeah, I do think back off. In fact, you were the very first doctor that we interviewed, and I was trying to think when that was. I was thinking it's back in like 2013 or right around there. And luckily, technology has gotten a lot easier since then, because I had a heck of a time getting that off and uploaded and things. But the change in, like, as we were talking about, just the students wanting to become educated and wanting to become specialized in this area has been phenomenal. We get requests quite often, and just seeing the other doctors and how they've kind of changed their views a little bit. And it's just so wonderful to see our last conference in Edinburgh. I mean, there was so many there. And I really attribute that to the work that you've done and John Stone's done and a few other significant doctors that kind of really have forged that path ahead. And so we really, as a community, really appreciate that work.
It's kind of, I do appreciate, though, that there's an enormous way to go. And I on behalf of everybody, I want to sort of apologize for the very, very long waits people have to access any sort of services, particularly specialist services. And I really hate seeing people after they've waited for such a long time. But it's just, it is a problem. It's so difficult to get things to change within health services when the health service, but it's not just about neurology, it's about the whole of medicine and surgery, and they're all these competing things. And when they don't really understand a condition very well, it's so easy to just say, "Oh, okay, we can't do anything for that." So I think
with you, how long does it take for typically? Do you know?
To see myself or the team I work with. So we have a waiting list, unfortunately, of around 6 to 8 months at the moment for an appointment, and then all of the multidisciplinary inpatient programs in the UK have waiting lists of longer than a year or around a year, and it's horrible. It's absolutely horrible, and it's horrible for patients, people and their families. All of us who work it don't like it because we can see the problems that are caused by these enormous waits. But the only, I've thought about it a lot, and the only solution I can think of, because what's been happening in the UK certainly is people have been putting a sticking plaster on this thing for a long time. So they chuck a bit more money at one of the inpatient programs, they open up a few more beds, then immediately those are filled. So the only solution I can think of is to try and establish a proper full pathway and get some money to evaluate it and prove, hopefully, that it really works. And if you can do that, then you have a big stick to beat people over the head with who have money to say, look, we have to do this. This is ridiculous. It's inequitable to treat people in this way, where you're taking people with similarly disabling conditions, for example, MS, and you are allocating, you're saying, well, for people with MS, they should have all of these things. I'm not saying people with MS is a picnic either, but we have all of these places should be there. But for people with FND, nothing. So recently in my department, we did a study where we were comparing people who came to the specialist MS clinic to people who came to the FND service. And we were looking at their access to treatment. So have they seen a physio, have they seen a psychologist, have they seen this and that? And the people with MS had massively more access to treatment, including mental health services, than people with FND. So I think that one can make an argument on inequality grounds that this is not right. But in order to, we need to have more evidence, really, to say that doing something normal for people with FND is going to help. And it's ridiculous, the things that I've seen and other people have seen of people revolving around the healthcare system with no help, really, actually having quite a lot of money spent on them sometimes, but all in the wrong way. So having the umpteenth MRI scan or umpteenth blood test is not likely to be helpful. Where if you invested that money in rehabilitation, maybe it could be.
Well, it's about really an equality to an access of care, right? That the same level of disability is somewhat equal. That there should, services that are also equal for those. You mentioned kind of a little bit about the even the psychological therapies. We have a question, and I'm just going to read it straight for you. As a psychotherapist, I understand that earlier trauma is one of the main triggers of FND. I'm interested to know if you would be considering other type of therapies rather than CBT, perhaps longer psychoanalysis, psychodynamic therapy sessions.
Yeah. So the evidence is pretty clear that if you take a big group of people with functional neurological disorder and you compare them to a group of people who don't have functional neurological disorder, then you find higher rates of past traumatic experiences, either in the distant past or more recently. So that is definitely there. I think that there's a rather different question, which is for that particular, say you have somebody who is in that situation, so they have FND and they have experienced past trauma. The question really is treatment of the trauma in its own right likely to be a useful thing to help that person overall? And I think that is an open question. So there isn't a single answer to that question. So it's not always the case that therapy for the traumatic experience in the past will be a useful thing. But I think it definitely can be for some people. I don't have a very good way of judging how useful that is. And the thing that I use in my clinical practice is to ask the person themselves and to kind of get away from some kind of very direct link saying, well, your trauma's the only problem. To say, well, with relating to the trauma problem, is that something which is an active problem for you? Is it something which is intrusive on your day-to-day life? For example, in the setting of post-traumatic stress disorder. So if that's the case, or if factors relating to the trauma and the way that it's changed relationships and emotions and so on, if that seems to be an active problem for the person, then absolutely treatment from that point of view could be useful. And I would agree with the person who wrote the question, which is that CBT may not be the right psychology treatment for that. And longer term psychotherapeutic type treatment, trauma related counselling, EMDR, the things which are used in that setting are definitely a reasonable thing to do. But it's an individual thing, and it comes with a conversation with the patient and with the person and a sort of frank discussion about the pluses and minuses of that. Because on the flip side of that, I have seen people who have had probably not very good, trauma-related counselling for past trauma, which was something which had more or less, had resolved to the extent it was ever going to resolve. And by doing that, everything has got a lot worse. And so it's a personal decision. It requires skill, and it requires a multi-dimensional way of thinking about functional neurological disorder, rather than sort of finding a trauma and jumping onto that and saying, okay, that's all we're going to do. So that's my feeling about it.
Well, I think that's helpful. We find with many patients that if they do feel that that trauma is related, that it's actually quite identifiable for them. They acknowledge it, they're like, no, mine is trauma related, and so I think that a lot of times patients do know themselves and maybe don't give themselves enough credit for, connecting when they do.
Yeah, I mean, on that subject, there's a question really about why it is that trauma is a risk factor for functional neurological disorder, and that's an area which needs scientific study, just like lots of other areas of FND need. And trauma and past experiences can have it has an identifiable effect on the way the brain works. There's even changes in brain structure which happen with people who've experienced trauma. So these are real things which for some people change the way the brain's working. And that, in its own right, can make people more vulnerable to developing other problems. But it's not an exclusive FND issue. So trauma is a risk factor for many, many different problems. For example, major depression or anxiety disorder. Yeah, it's a complicated issue. But I agree with you. The idea that sort of one has to go digging around for a trauma in order to help somebody with FND does not, to me, make any scientific sense. And I think, generally speaking, people who've had traumatic experiences know they've had a traumatic experience, and they know to what extent it's an active problem for them.
And I think you also bring up a good point, is that it does change the brain. And one of the questions we had at the beginning relates to some of the new studies that have come out. I think recently there's been a lot of talk in our Facebook groups with Dr. David Perez. He had a lot of new studies come out with functional MRIs and changes in the gray matter and things like that. And he's actually going to do a webinar for us next week during Awareness Week and show us the slides and things like that. And so you don't have to go really in depth in that, but do you have anything else you'd want to add, kind of about how that does change? They're not mutually exclusive, I guess.
So I think that on just a very, very basic level, it shouldn't need to be this way, but the fact that you can see changes in the way the brain is wired up in people with FND demonstrates that it is a real problem with the way the brain's working. Now, we all know that, but it is useful to just, these studies are useful just on that very basic level. But what sort of studies kind of put together is that there is kind of misconnections often between these higher levels of the nervous system. So the levels which are much more about sort of access to the body, like I was talking about before. So rather than sort of a more basic wiring level of the system, we're talking about things which sit at this interface between people and their bodies and their experience of the bodies and their control over the body. And that's the bit that's gone wrong in FND. In some studies, you do see abnormal connections into what's called the limbic system, which is the bit of the brain which is important in emotions. It's often talked about as the emotional part of the brain, but it's a bit more than that. So it's not really just the emotions like I feel happy, I feel sad, it's a conscious emotional state. It's also much more primitive states about fight or flight type responses, sort of orientating responses to things in the environment. So things that are happening at a very basic level. I think it's interesting that those circuits, which are very sort of basic, old part of the brain in a sense, are sort of seem to be abnormally connected to the bits of the brain which we have more control over, more voluntary control over, like sort of movement and sensation parts of the brain, the sort of cortical part of the brain. There's obviously a very big step from that to understanding, well, what does that mean for treatment? But that's always the case in these sorts of studies. So these more basic scientific studies of how the brain's working hopefully will start to unpick things for us. And what I'm particularly interested in is how they might help stratify patients, so divide up people into people who might be suitable for specific types of treatment. Because that's one of the big problems at the moment, is that we do have some treatments, but we don't know why it is that certain people do really well with, say, a physiotherapy approach. Some people do really well with psychological therapy approach. Some people do really well with multidisciplinary approach, but lots of people don't. So what's the difference between those people? And how could we pick that out to begin with? And also, how could we maybe start to develop some new treatments, something different from what we have already?
Well, do you think as we start to learn more about the brain and identify some of the structures and changes maybe in it, is that going to possibly change some of the labeling? Another question that we have is a person's asking, often GPs use psychosomatic as a terminology, and that's one word that the dictionary version, I think, the connotation and the denotation are very different somewhat to one another, and what the general public, how they think and perceive that word, perhaps.
It's not an easy word. I think that, I think the problem about it is that anything which has the word psycho in it, like psychological or psychosomatic, automatically suggests to many people that that is something that one has voluntary control over. So one could choose to be like that or not. And therefore, the problem is really a behavioral one. It's a sort of personal choice for whatever reason. And that's just not true. But that's also not really what the word means either. I've been, in what I said a few moments ago, talking about the interaction between the conscious part of your brain and the bits of the brain that are processing information from the body and translating what you want to happen into your body doing something. Now, that is, in some ways, you could argue, well, that's what the word psychosomatic might mean, because it's talking about how our mental processes interact with our bodies. But that has nothing to do with something which is a voluntary problem, or something that somebody could choose not to do, or something that's a lack of moral fibre. We're talking about real processes which have their origins in the way the brain is working. So I think that's why we need a different language. And unfortunately, these words like psychosomatic, they're to some extent, to me, they're unrecoverable in terms of what that means to people when you say it. And that's why I think that the most of the term about functional neurological disorder, even though it has its own problems, is an attempt to move on from that and to try and have something which doesn't have so much baggage associated and which we can define in a better way. But
Well, I think we're getting towards the end of our time, but you've really touched on so many important issues, and I think that the words that we use and trying to find that communication seems to be a huge barrier in patient care and can have such an impact on patients. Do you find that is sometimes, even as you're trying to tell a patient, we know that you didn't create this, do you sometimes have a difficult time trying to undo what has maybe been done and cause some of that emotional trauma from the diagnosis itself?
Yeah, I do, but I think that it just is fundamentally a really hard thing to understand. I accept that often explanations that people have been given make it a lot worse, but there's also just a fundamental issue with understanding this sort of problem. It's not the way that we're taught to understand how the brain is working. we're taught that there's a kind of real bit of the brain, which is a bit sort of there, and then there's a sort of mind bit, which is maybe somewhere else. And the mind bit is something which you can control. The brain bit is something you have no control over. And so if you're talking about something which is sat at the interface of those things, it immediately sounds like something which is either crazy or made up or not real. The thing that I think about a lot is that it would be completely incredible to me if functional neurological disorder didn't exist, because this is the way the brain is put together. The brain is put together with a sort of enormous automatic machinery which does an enormous amount of stuff with both in terms of moving and sensation. And then we have a bit on the top, which is our conscious awareness, which we can direct around and do amazing things with. But there is an interface between the two things. So if I decide to get up and go and have a cup of coffee, I'm going to have that thought, and my brain is just going to do it. And suddenly I'm up walking. I have no idea how I'm walking, but it's still, I've somehow got it going in some way. There's billions of sensory receptors in the body, but I'm receiving only a tiny proportion of that. It'll be a nightmare if I got everything. So there is this system there, there's this interface, and that's the thing that goes wrong in functional neurological disorder. And so if that interface is there, it has to be able to go wrong. It just stands to reason it has to go wrong. And if it went wrong, you'd expect exactly the kind of symptoms you get in functional neurological disorder. So it makes sense to me that this exists because this is the way the brain is put together. And if and by understanding that interface, we should be able to help more and more people improve and recover from what's a very, very disabling disorder. I think that's I think that's where we are with it. But this whole schism, if you like, between psychosomatic, psychogenic, I think those words unfortunately are unrecoverable because of the stigma attached to them. We need to have a different language to be able to talk about it. Sorry, I went off on a slight rant there. I apologise.
No, it's important, and I think it's an important discussion for us to have. And we have run out of time. There's a few questions I can, people are wondering about, like support for families and things like that. And I think it's important for people to remember that some of like other support that is available for just chronic illness, you can still access some of those support groups and stuff probably in your local hospitals, clinics and things like that. Contact them and find out, is there something for families of chronically ill patients, or is there support for chronically ill in general and things like that. We have tried setting up some programs around.
I think people should recognise, I know it's often not the case, but if people have chronic illness, then illness-related financial benefits, which I know are not generous anywhere, but they do exist, they are meant to be based on symptoms and disability. They do not depend on the diagnosis. So somebody with MS can have virtually no symptoms. They may be wheelchair dependent. Those benefits should come on the basis of symptoms and disability. And that should go for people with functional neurological disorder just as much as anybody else.
Absolutely. And with that, we want to thank you again for your time that you've given to us. We want to remind everyone that next week is World FND Week, and we'll have live webinars throughout the week. You can go online to fndhope.org, find out how you can get involved in other ways. And we just look forward to spreading as much awareness as possible. And thank you.
Thank you for FND Hope for everything you do, and thank you for everyone out there as well. All your support is fantastic. It's getting us where we're getting to.
Thank you.
Pleasure. Thank you very much.